All right. Good morning or good afternoon, depending on which time zone you're in. My name is Tamia. I'm one of the board members of FLaNET, and I have Dr. Strasberg here as well with us. And our guest speakers, Lisa Yen and Tom Bajoras, our patient advocate and patient duo, patient advocate and patient duo. I'll let Dr. Strasberg introduce himself, and then we'll let Lisa and Tom take it from there.
Hi, I guess good afternoon. It's nice to talk to you all. John Strasberg. I'm a medical oncologist, head of the neuroendocrine program at Moffitt Cancer Center. And it's really a pleasure to be able to talk to both of you. Thanks for taking the time.
Thank you for having us.
Yeah, glad to be here. Glad to be anywhere.
So Lisa, maybe you can just briefly introduce your role in FLaNET and how you got into this, and then both of you can talk a little bit about the journey of dealing with this cancer.
Yeah. Well, and the cancer, right? It's although it's on the forefront for many of us, especially right now, it did not always define who we are. So my background is as a nurse practitioner, hospital, not to be confused with hospice, but as a hospitalist for more than a dozen years. And so I was working in hospital medicine, doing my own thing, really loving it until my husband was unfortunately diagnosed with metastatic pancreatic NET in 2015. And so I came to FLaNET for the same reason all of us go to patient advocacy groups to get information, support, help. And I was actually really amazed by the quality of the information, by the education, and then also the support and the connections made. So I was invited to join a few years later after Tom got to a point of stability, and really excited to give back. So my role in FLaNET is as a director of programs. So I help create content. That's the thing. And that's me. So we live in Los Angeles. It's myself and Tom, and we have a dog.
And I know a lot of people are familiar with FLaNET. There's lots of patient organizations around the country, but you've done a really amazing job, both bringing a very large group of people together to network and learn more about the disease, but also with the checklist, the FLaNET checklist,
The Net Vitals.
FLaNET Vitals, right? So just a resource for patients to go to their doctor and really get more granular information about where they fit in as far as this very heterogeneous disease.
Yeah, thank you. As you can see, it's personal for us. So we create the content that we find useful for ourselves or each other. The gaps and the needs that are identified in the community are ones that we're seeing. And so we just try to create content that meets those needs.
And maybe you can tell us a little bit about how it all started, how the diagnosis was made, and what kind of challenges occurred along the way.
Sure, I can tell you that. So I was diagnosed a little more than 9 years ago, and I definitely had a very non-cancer life before that. It wasn't until December 2014 I could tell there was something wrong with me. I thought it might be the flu, because at that time it seemed like everyone had the flu. And so the month of December, I was very tired, and I just thought it would get better. So it was a complete surprise on January 1st. No, it was New Year's Eve, where I started throwing up blood, and so I knew there was something serious wrong. I went to Lisa was working at the hospital, and so on January 2nd, I went into the hospital. I was admitted directly into the hospital, and I went for I was going to have an upper endoscopy, but they told me that actually my blood count was, I think my hemoglobin was like 4 or something, so I had to have a transfusion first, and then I went for the upper endoscopy. It was my first time ever being admitted into a hospital, so I went big my first time, and after that, I didn't know what happened because I was out. So the next 3 days, actually, I don't have a story for the next 3 days, so Lisa can tell you what happened while I was out.
Yeah, so it was completely unexpected, right? This is Tom's first hospitalization. He was only feeling like flu-like for a couple days. He threw up a little bit of blood. So for those of us in the medical field, it was like not super impressive, but he was found to have like his blood count had dropped in half. And then all of a sudden he's on the ventilator and not able to talk because what we found on the upper endoscopy was he was actively bleeding. So he's kept on the ventilator. And it was just shocking. It was far worse than what anyone could have expected. He had gastric varices, so he had really big and large veins, and this was really bad news. And the doctors, who thankfully were even though they were community doctors, they were familiar with what was going on. They said, "Look, Lisa, let's take it step by step. Don't even worry about the big tumors that you see there. You got to stop the bleeding first, and we'll take it step by step and take care of this." And so a lot of chaos for someone who is used to being calm during chaos. And even though I had dealt with a lot of death and dying over decades, it's a really different story when it's your own husband. And we never, had to encounter the situation. We've dealt with a lot in our lives. And, then the next 3 days it was, holding his hand, trying to get through this. And I was immediately thrown into the caregiver role. And here I was standing in the ICU, holding his hand, still wearing my like white coat, stethoscope, and just shocked that this was happening to me, to us, and the world was turned upside down. So, the doctors did a lot of quick thinking. They stopped the bleeding, and then biopsied the tumor. And in the time that he was asleep on the ventilator, got the diagnosis back that yes, indeed, he had not the terrible type of pancreatic cancer, not the worst one, thank goodness, but the better one, which is the neuroendocrine tumor of the pancreas. And yes, even though the tumors were large and had already spread, this was in fact good news because we had time. So nothing could have prepared me for this kind of shock and news, and yet and unpredictability. But I felt pretty supported as much as possible. So then we just continue to take things step by step and breaking it down. So when Tom woke up, he met with the surgeon, or the doctor first, who explained the whole situation, and the surgeon. And Tom was told, your job is to go home and to get as healthy as possible so you can have major surgery. And it's hard when you're exhausted, you're in shock. He lost a lot of weight from, not eating for a couple of days. He was weak, and you're overwhelmed by this new diagnosis, by information that you've never heard of. I mean, I'd only heard of neuroendocrine tumor and carcinoid, never had to deal with it. And so we tapped into resources, our friends, family, and started learning and trying to weigh that with, making this decision at the time. So I'll hand it over to you.
Okay. So it's been a 9-year journey, and it's been long and complicated, and I obviously can't really, we don't have the time to go into detail about all of it. So I'll touch upon a couple of the high points, I think. I actually typically don't necessarily think in medical terms. I'm not by any means a medical person. Lisa handles all the interfacing with not just doctors and also insurance and all those sorts of things that, you know, have to be navigated with a serious illness. So I can talk a little bit about some of the stuff that we did, but not in detail. So obviously I had my major surgery at the end of January 2015. And it was my first surgery. Again, go big, you know, if you're going to go. It was a very, very big surgery. It included, you know, removing half of the pancreas, removing a large part of my liver, gallbladder, the spleen, and then the recovery from my surgery was uh, really long and really difficult. It was not anything that was expected. It really kind of dominated my life, probably about 2 years. Unfortunately, part of the reason why that's true is that when I went for my first MRI checkup after the surgery, which was only, I think it was 2 months,
Yeah.
about 2 months after the surgery, it the MRI showed that there had been progression already. So uh, I was not in a mode of simply recovering. We were right away back in the mode of making decisions about treatment and, you know, what to do moving forward. One thing I'll say at that point is that uh, I actually have a background um, that helped me with this. Um, I'd I'd been a small business owner for at that point, I guess it was about 23 years. And I learned to approach a problem in a certain sort of kind of a systematic way, where we sat down and rather than just talking about like, well, what are we going to do about this progression? We first talked about kind of our bigger overall strategy. Um, I sort of think of it as it's being like an investor where you sit down and first thing you do is you say, well, what are my goals? How risk tolerant am I? Um, you know, that is how much risk am I willing to take on for a certain expected benefit? And, you know, talking through those things helped us sort of establish a kind of a standard that we could look at for all future decisions, not just this first one that we had to make. And we also, you know, learned how to sort of compartmentalize. You know, obviously, you know, we could talk about cancer 24/7 if we wanted to, but you know, early on we decided, okay, you know, no matter what the situation was, we were gonna periodically take some breaks, like, you know, have like a date night that uh, doesn't include the word cancer. Uh, so that was the first thing we did. And then, of course, I started on lanreotide monthly injections. And within 3 months, I think another MRI showed continued progression. So obviously, the lanreotide by itself was not sufficient to control my NET. And then I think it was Lisa who, through LACNETs, learned about PRT. And we ended up, you know, interrupt me if I'm leaving out anything, but I'm trying to move forward. We went to Excel Diagnostics in Houston, who were offering PRT under the Texas Right to Try law. They had been a site for the
Better one.
for the Netter one trial, which had closed at that point, and the the results from the trial were fantastic, and we were awaiting FDA approval, but it was not FDA approved at that point. So I was able to get PRT. And
this was under the recommendation of our medical team. This was not
Yeah.
us going
Yeah,
ourselves.
yeah,
Actually, our
yeah.
doctors looked at the dotatate scan and said, go get PRT, go get LU177 dotatate PRT, and go get it in Houston. You know, we really, this was a strange time because it was before FDA approval. There are options, and yet the cancer was spreading. It was spreading at a certain rate. It spread to the bones. And we didn't have a break. This whole time we're still in sprint mode for these, it ended up being 2 years.
Yeah. It's said, I'm sure you've heard that NET is like a marathon. For us, at least, it was a very long sprint at first. And I guess I left out something important, which was that I did have a dotatate scan. That was actually, I had 2 dotatate scans a year apart, and that was before the dotatate scan actually was FDA approved also. So I was able to get that as part of a clinical trial, and it did show the presence, the very, very strong presence of the somatostatin receptors. So that's what led us to PRT. But the PRT was that was a whole experience. The bottom line, though, is that when I went back for my checkup
3 months after.
3 months after the last of the 4 rounds of treatment, the scan showed no evidence of disease. And it was so amazing to everyone there that they actually thought for a moment that they had the wrong scans. And it was extremely rare to get that kind of response from PRT.
Yeah.
Um,
Yeah, the doctor was like, wait, hold on, was that the right patient?
Yeah.
I had to double check and triple check, and was very pleased to give us the good news. It was the first time he had seen a complete response, and we knew that wasn't what we were expecting. And of course, we were super grateful because it was the first pause in our 2-year sprint of getting, beyond survival mode. And after that first 2 years, to then allow the time finally in year 3 to recover.
Yeah.
So we spent that 3rd year recovering.
Yeah.
And
that was just recovering from the surgery, because like I'd never had time yet to recover from the surgery. And so then I worked with a pain management specialist. I stated my goals. I said, I want to be pain-free. I want to be drug-free. She said, that's a possible goal. So we worked toward that. And then in 2018, we celebrated by doing our first, I think it was our first international trip since my diagnosis. Now, we used to do a lot of traveling. And in fact, when I first started feeling sick back in 2014, we had just gotten back from Japan. And so, we were used to doing this sort of once a year big, save up all your hotel points sort of vacation. And this was the first time we were going to be able to do that. So we celebrated by going to Iceland, which actually was the easiest place to get to for us, because we were able to fly to the East Coast and then rest and then fly on to Iceland. And while we were in Iceland, we did all sorts of crazy hiking, up glaciers, through caves, and it was just like a big celebration that it really meant, we're back.
yeah, establishing a new normal, having a goal to work towards. As we planned the trip, Tom then realized, wait, we're going to be hiking, X number of miles. I need to train for this. So he started increasing the amount of walking he was doing every day, training physically, mentally, to have a goal to work towards. And that's always helpful. Because in that year 3, we were not in active treatment and starting to process all that we had been through. over the first 2 years. And it's hard. You start kind of processing the trauma, the grief, the loss of life as you thought it would be, loss of changes in your body. Both of us had, our futures were different. I had decided to hang up my white coat, and that was something that it was a surprise, a shock, and yes, I chose it, and yet it was still a loss, of life as I knew it, and my hopes and my dreams and my future, both of us. And so processing all that, struggling, working through depression, with therapy and support, and really diving into the support at that time. So having a goal to work towards, having a plan towards finding a new normal again was really, really important. And then having that milestone for celebration. So Iceland was really special and significant for us.
Yeah.
Yeah, so we were able to enjoy a couple more years of just stable disease, being boring, which is our goal, being boring on scans, having the cancer in the background, having happy visits with our oncologist where, he's like, nothing to talk about except maybe theoretical. And then 3 years from his first PRT treatment, at that time there was tumor progression. And now dotatate scans, Lutathera, they're all FDA approved. At the time of progression, Tom did repeat PRT with Lutathera now, doses 5 and 6, so 2 doses. Locally, we didn't have to travel for it because it's FDA approved. And that was almost 3 years exactly from his first treatment. He again had a really fantastic response. We were able to just kind of, snooze through it, go back to life. And then 2.5 years later, again, at the time of progression, it was decided again to repeat it. So he had a total of 8 doses. And his last dose of Lutathera was almost 2 years ago. So yeah, so the last few years have been nice in that we've been able to cruise along, make decisions as we need to, but they weren't decisions that overtook our life. It was a different kind of mode. We didn't feel like we were just barely treading water and surviving. And all of the tools, all of the resources, the skills we learned along the way served us at each decision point. And each decision point is different. Similar, different. Sometimes you go the same thing, sometimes you go to a different thing. But all of the strategies that Tom was mentioning, our goals that we set, the strategies we set, our skills, they served us. We also had, kind of decided roles, right? It's kind of like, if you're taking a long car trip, deciding who's driving when and how. I mean, sometimes some people are comfortable driving during the city, some people drive during, the country. So you take longer breaks, or some people like to drive the whole time. So it's just different. And no person or two people are the same in how they navigate that. So that's how, and it can shift. It can shift a lot, right? You might be going through mountain roads or windy roads. So it really just shifts, and it depends. And we always, come together and discuss it collaboratively. And yeah, so I know that I take in a lot of the medical things and distill it down and we talk about it. But this decision is ours together because we have, we're both living through it together.
Yeah.
Yeah. And then most recently we had one more decision because we were kind of thrown for a loop when about a year ago we started seeing some spots and we're like, okay, well, we have something else that's going to be down the road that we have to decide. You can never predict what and where the tumors are going to appear and what kind of pattern it's going to be in. So you try to guess, oh, maybe it'll look like before where small spots everywhere. And then maybe you would treat it this way. But instead of being small spots in many places like it's been in the past, it was one rogue tumor that ended up showing up. And we ended up exploring different options. And then in the end, Tom had surgery again, and that was 8 weeks ago today. So, and he's doing remarkably well. for 8 weeks out of surgery,
Yeah.
out of a liver resection surgery.
Yeah. Yeah. Of course, it was a much smaller surgery than the previous time, but it was, still major surgery. And it was, I would say, 100% successful. The pathology report showed that, the margins were all clean, and the, there was this one tumor that had uh, mutated to a high grade Ki-67 of somewhere between 64 and about 46 and 64, somewhere in that range. Quite a lot higher than I'd ever had before. And so the decision to have the surgery was actually, definitely in hindsight was the right decision. We had thought about maybe looking at some ablation technologies, and we actually, when we met with the surgeon, she was pretty sure that we should move forward very quickly with this. And it's a good thing we did, because the tumor was larger and more aggressive than they had thought based on the scans.
Yeah, we really have, we're really grateful for our medical community, our treating providers, our friends, and, all of you, because, yes, there's a lot of education and information out there. And with the relationships, then you build a trust. And some points you can educate yourself as much as possible, but sometimes you just trust and you move forward, because we can't know everything. We don't have that magic ball. If any of you have a magic ball that you would like to share with us, we would love that, or that magic wand, but we don't yet have that magic ball. So there is a degree of trust where at some point you just have to trust, make a decision, not look backwards, and move forward. And that's what we did. And we're glad we did.
Yeah. And that brings us to today, where we're actually waiting to get the read from the MRI, the 2-month post-op MRI. But the initial read is, it looks pretty good. So
Congratulations on that. That's very exciting. It's like you can take a deep breath and release it now.
yeah.
Yeah, so it's inspiring the way you were able to support each other, and also enlist the community to help out as well. And everyone's journey is different. Yours is interesting that you were able to access PRT even before it was approved, and pretty much continue with this one type of treatment. There's different treatments for pancreatic nets, lots of questions about how best to sequence them. But PRT treatment and retreatment, seems to have worked quite well.
Yeah.
And also, unlike other therapies that need to be taken on a daily basis, it was more of a situation where you were getting treatment for very limited periods of time with long durations of remission in between.
Yeah.
Yeah, that was helpful, because then we could, yes, it was a lot during that time, especially when we had to travel. But then we could put it behind us. We could put it aside and move on with our life. And at that point, even before deciding about PRT, we sat down and again, we talked about our goals and priorities. And because Tom was taking so many pills, he made it really clear, like, I would really not want to take a pill right now. If I could do something and put this behind me, that is my preference. So patient preference, this is where it comes in, right? So we sat down and we talked about, but it was because of where we were in that part of our journey. So it might be a different decision right now, because, when you have something that is so big, like a surgery or PRT or embolizations, it takes, you lose days or some time because there's recovery time, versus taking a pill that may not affect you so much in terms of time loss. But, he really said, look, I cannot take another pill. I have too many. So, yeah.
And for those of you in the audience who are not too familiar with the terminology, PRT is basically somatostatin analog that's attached to a radioactive isotope. And so it targets tumors that express somatostatin receptors, which are most well differentiated neuroendocrine tumors. And The pancreatic ones that are very avid on dotatate PET scans, meaning expressing a lot of somatostatin receptors, tend to do quite well as far as tumor shrinkage. And clearly that's what happened here. But, increasingly we're seeing and in those circumstances, it's sometimes important to, well, it's always important to first recognize what's happening and act very quickly. And sometimes it's just one tumor. Tumors can acquire mutations over time and become more aggressive. Sometimes it's many tumors, but in many cases, it's just one tumor or two tumors, in which case you can try to eradicate those tumors through surgery or through ablation. And in your case, it definitely sounds like surgery was the right answer. I guess the question at this point, and not to get too much into medical weeds, but assuming that there's no evidence of any further progression, or is there any consideration of adjuvant treatment?
That's been a big topic of discussion among our doctors and others in the NET community. There's no data around this, so this is all, again, individualizing care and what's best. So it all depends on what is seen on this MRI, because do you treat something? Do you treat with something that kills tumors, but then the tumors can change and mutate, or do you wait till you see something and then try to kill the tumors? So for right now, we're continuing on lanreotide, the somatostatin analog, which we've increased to from every 4 weeks to every 3 weeks. Because I am a nurse practitioner, I'm able to give it at home. So it saves doctor's visits and such. So it's pretty convenient for that. And it is covered, or it has been covered through the pharmaceuticals patient copay or patient assistance program, Ipsen Cares, they've been fantastic. So we've done that, and we're waiting and trying to also stay in the moment, because it's hard. You want to think ahead and yet not worry too much about what's ahead. Because otherwise you don't want to live in the past, you don't want to live in the future. You need to live in the now. And just take one day at a time, because looking too far forward causes anxiety. Looking backwards can cause depression. And so the best place is really to stay in the now, which is really hard with living with neuroendocrine tumor, especially like this. I mean, Tom does not have a really slow growing, well-behaved, small bowel NET or whatever. He has this cranky, grade 2 intermediate that has changed to grade 3 pancreatic NET that's never really behaved well. And the other thing that it's not just about the numbers. The other thing that our medical team has really highlighted for us is it's about tumor biology. So sometimes you get stuck in our head. I know we all teach and learn our Ki-67 and our grade, but it's more about the biology. So when that one tumor started growing, it was important to look at the growth and how tumors are behaving and respond to that, rather than get stuck with just, oh, well, the Ki-67 was this, or even now the Ki-67 is really high, so should we be freaking out about that? But really watching, waiting, having some patience sometimes, and knowing when to sprint other times. And that's a lot of it is, again, working with our team. And then, and continue on through the journey. So some people describe the journey as, again, a marathon. Some people will say it's a roller coaster ride, which it certainly is. For me, I feel like it's more like, the Tower of Terror that Disney used to have, where the bottom just drops out every once in a while. You don't know when. It can feel like that sometimes, because you don't know when your bottom will drop out. Sometimes sometimes you don't know. And it just kind of varies for each person and each situation. And it can vary even, it's been more than 9 years along the journey, where you have those slow, okay, we can cruise along, enjoy lots of trips, and then other times where the bottom falls out and we got to run.
Well, I wonder whether we should open it up to anyone else who might have questions. Amy, are we able to do that, or?
Again, the chat is definitely open, so feel free to type in any questions or unmute. And as people are thinking of their questions, I have a question for you, Tom. I know you've been blessed and very lucky to have Lisa by your side. Not everybody has a healthcare professional that they're married to or in the family, right? So if you were to give patients advice that are either newly diagnosed or have been diagnosed for a while on what you would have wanted or what you would recommend they do in a situation like this, what advice is that?
Well, yeah, it's definitely not something to do alone. Uh, if uh, if you're fortunate to be married to a professional healthcare provider, that's great. But of course, a lot of us, most of us, I think, are not. So I think it is really important to get it plugged into a community of people who are living with NET. I'd never heard of NET before, and when it was explained to me what the diagnosis was, the doctor actually did explain it really well, and but the one thing that stood out for me was the statement, oh, well, fortunately, it's the kind of cancer that Steve Jobs had, which for me was weird because I'm like, he's dead. Uh, and unfortunately, the only time we really ever hear about NET is the occasional news article about some celebrity who has died of NET. And obviously, there's far, far, far more people who have not died from NET but are living with it. And we don't write articles about them. Occasionally now, I think things have changed. Occasionally, we are getting some articles about celebrities who are diagnosed with NET. And that's a really good thing because what we need to do is connect with the community of people who are living with the disease. And it's not just for mutual support and hope, but it's also for the exchange of information and, and just everyday inspiration to get through it. So I guess my number one uh, piece of advice would be to get plugged in to some sort of community.
Absolutely. We have a question here about your business and how you've been able to juggle that with variances in your treatment status and things like that.
Yeah, I was in the process of extracting myself from the business, moving into a sort of a semi-retirement, and then my diagnosis just accelerated that. Fortunately, there was already a management team in place that was, already running the company. And when I stepped aside, it was pretty smooth for the company. I'm still involved in a sort of advisory consultant way with the company, but it was time for me to move on anyway. And fortunately, the company was in a good enough condition to hand it off. I'm still an owner in the business, but I basically have like maybe 3 or 4 Zoom calls per week, and that's my involvement at this point.
So there's a few other questions in the chat. One question about whether Tom had 3 rounds of Lutathera, and the answer is basically yes. He had the standard course of 4 treatments, and then there's increasing evidence that you can administer more than 4, and one way of doing it is administering 2 more and then 2 more after that. 8 is about the maximum that almost anyone has ever received. Whether people, undoubtedly some people can tolerate even more than that, but there's probably a decrease in benefit over time, as with most treatments.
Right.
You can even see in my case where the time to progression after each of those sets of treatments was getting smaller.
Right.
And that was
And then another question about risk versus reward when choosing treatments, and how would we evaluate the current status of alpha PRRT? So just to explain a little bit, Lutathera uses an isotope called lutetium-177 that emits high energy electrons. That's called beta radiation. There are newer radiopharmaceuticals and studies that are looking at alpha radiation, which emits 2 protons and 2 neutrons. So it's a much larger particle over a much shorter range. And the question is whether that's better than lutetium, both in terms of efficacy and safety. And we don't have really a great answer to that yet. You know, preliminary evidence suggests it's probably more effective. We're still learning about side effects, but there are several clinical trials currently enrolling patients who have already received Lutathera. We have several of them at Moffitt. One of them is looking at actinium. It's a randomized trial of actinium dotatate versus standard of care. And then one that's just about wrapping up at looking at lead-212, which is another alpha-emitting isotope. There are other alpha studies taking place elsewhere in the country. So it's targeting the same receptor, the somatostatin receptor, but using a different type of isotope and therefore a different type of radiation. And you know, I would say it's encouraging. These are clinical trials. We feel that in most cases, not all cases, but in most cases, if someone is eligible for a clinical trial and they've received standard of care, at least several lines of standard of care, then enrollment in a clinical trial is often not only in the patient's best interest, but also allows us to move the field forward and develop new treatments.
Okay, we have another question here. My father died of pancreatic cancer. As a DNP student now, I often think about the day I may have that subtle right upper quadrant abdominal discomfort. Is there anything I should be considering as far as screenings? There was no previous family history for my dad, but he was 83 when he died, and I'm 63 now.
So, yeah, I mean, it's not clear whether the references to pancreatic adenocarcinoma, which is a standard pancreatic cancer, or pancreatic neuroendocrine tumor. But right now, as far as neuroendocrine tumors are concerned, we don't have any screenings for most patients. Most cases are not hereditary. It's also a rare cancer. And so screening of the type that's done for common cancers like breast cancer or colon cancer that are, you know, much more common, don't exist for neuroendocrine tumors and likely will never exist because, you know, these are very rare cancers. That being said, there are hereditary syndromes that it's important to be aware of, and increasingly, well, first, you know, as far as the standard hereditary syndromes for pancreatic NETs, the most common is multiple endocrine neoplasia, which is associated with other endocrine tumors in the pituitary and in the parathyroid glands. There's some other syndromes, but we're learning that even cases where there's no clear pancreatic neuroendocrine tumor syndrome are associated in some cases with hereditary mutations like BRCA, for instance. And so what we've started doing in many cases is offering genetic screening for a lot of patients with pancreatic neuroendocrine tumors, especially if they're young. I'm wondering if you underwent genetic screening.
Yeah. Yeah.
About 6 months after his initial diagnosis, when the dotatate scan showed some uptake in the head of the pancreas and his tumor was in the tail of the pancreas, then there was the thought that, you know, does he have MEN, what you were talking about, MEN1? And so he underwent genetic screening, and with pancreatic NET, you know, they were really looking for that and VHL. So it was a really good experience. You sit down with the genetic counselor who gets a very thorough family history, and then explains what they're going to test for and what that might mean. And then afterwards sat down with us and we went through the results, which were negative, thankfully. She also told us that, you know, things change over time. So she said, you know, in 5 years, reach out to me again. And if anything has changed, if the tests, because the tests sometimes improve or they have new things that they're looking for. So reach out to me again and touch base and see if anything else needs to be tested. So we did that. And And that was, interesting to, circle back. It's hard to think, like you think 5 years is a long time. I can't even imagine, being alive in 5 years or what's going to be happening, what my life will look at like. It was hard in that first year to imagine that. So yeah, 5 years down the
Did they
road,
run another panel when you went back 5 years later?
they
Yeah.
ran, yes, because she said some of the tests had improved, particularly the one for VHL. Mhm.
Well, nowadays, you can run, instead of just 1 or 2 mutations, you can run a large panel of about 100 mutations. And so
Yeah.
we're picking up things that are not necessarily the standard neuroendocrine syndromes like MEN1 or VHL or neurofibromatosis, but other hereditary cancer genes that, of course, have implications for family members. And in addition to the germline testing, which means testing blood or saliva, you can also test the tumor. And what we're learning is that, usually you don't find mutations that can be directly targeted, but over time you can accumulate new mutations. And undoubtedly, if they look at this tumor that was just removed and do genetic testing on that, it'll be very different from the
Right.
initial tumor. And that might be something worth looking at. Sometimes we see a high tumor mutation burden, for example, in patients who have, lived with many years with the disease and have had prior treatments. And we're trying to figure out whether that correlates with potential response to immune therapies. Because we know that most well-differentiated neuroendocrine tumors don't respond at all to immunotherapy, but the exceptions may be patients whose disease has been exposed to a lot of different treatments and has transformed over time, acquired a lot of mutations, and then immunotherapy, which may not have worked at the beginning, may become effective later down the road.
Yes. Yeah, it's really amazing, looking back, right? It's 9 years, which is like amazing. I can't even believe we're almost to double digits, but how much things have changed, right? Even that period between the two genetic testing, even as you're talking about testing the tumor for different mutations and all the different things that can be tested now, what we're considering with this now 8 weeks ago versus 9 years ago with his first tumor, and specific mutations that people know now to look for. It's really amazing. So I know one of the NET experts in one of our podcasts talk, and many people will talk about this journey, the treatment strategy being like trying to kick the can down the road. And, in normal non-cancer world, that's not necessarily a good, kind of saying, but in the cancer world, it's a good thing because things keep changing. And the information, what we know, the treatments available, and the more we know, and the more empowered we can be, and it guides us with the treatment decision. So that information and really understanding our tumor is really, really, really critical. And I just want to circle back to what Tom was saying about like what the advice was at the very beginning, and getting support. So we knew about LACNIS. Actually, one of our friends called within the first, few weeks, but the meeting was like in person. It ended up being like 2 days before his surgery, so we weren't going to go. And me being kind of in the medical world, I thought, I don't want to go to a support group. It's going to be a bunch of people sitting around a circle, holding hands, crying, or singing Kumbaya. I'm not that kind of person. And I went to my first meeting, like, I want to say like 9 months later, because we were at a point where we were stuck and we were having to make decisions. And I was blown away by the quality of the information. And so while I initially went for information, and that's important, I stayed for support. And the support that is found through these groups, yes, through other patients and caregivers and also the medical community, it is so critical. And some of the support looks like information and education, and some of it is just knowing that you're not alone. And as things change in this information, and people like Dr. Strasberg and Tamia, find new things to share with the groups, this is the source of the information. And to know people like you are out there is really hopeful and helpful as well. So.
Thank you. Very kind.
We
Anyone
have
have any other questions?
Judy, were you wanting to ask a question? Okay, guess not. Any other questions? And feel free to unmute. You don't need to type a question into the chat.
All right. Well, if there are no other questions, I really want to thank you for taking the time to, both of you taking the time to share this. And again, FLaNET is a amazing organization. That's kind of why we're inspired to, try to form a similar organization in Florida. Hopefully it'll be half as successful as yours in terms of the support it offers to the community. I really appreciate it.
Thank you so much. Thanks for this opportunity. Thanks for all you do.
Yeah, thank you.
Thank you, everybody
Yeah.
that joined as
It's
well.
thanks to you that we were able to, get the Lutathera, right? Because of the work you did as a principal investigator in the Netter-1 trial, which you see now, there's a direct benefit. And thank you.
Thanks.
And
Bye.
Have a good rest
Bye,
of the day.
everyone.
bye-bye.
Bye.